So welcome. This is the seventh of our improvement webinar series, and this is delivered by the Emergency Care Improvement Support Team. My name's Dr. Daniel Smith. I'm a respiratory registrar up here in Nottingham and one of the ECIST clinical associates. And we've got a lot of the ECIST team here to support us today. I can see on screen Dr. Aurora, one of our clinical directors, Chris Green, and Richard Clarkson, two of our presenters that I'll present in more detail in a second. So our presentation and our webinar today is about optimising your workforce. But obviously, this is a topic, workforce and optimization, that we're never going to completely get through in a whole hour. And so what we're going to try and do today is provide some tasters, a couple of amuse-bouche, for want of a better word, and then a Q&A for the last 20 minutes or so, where you guys can ask your kind of personal questions for your own organisations. And we've got a really great range of speakers today from both a nursing and a doctor and an operational informatics background. So hopefully something for everybody. We're going to discuss the factors that contribute to workforce optimization. That's going to come from 4 of our expert speakers, and then we're going to try and leave at least 20 to 30 minutes for a Q&A panel. And we've got a couple of extra experts coming in to help us with that panel as well. And of course, in a whole hour, we're going to completely fix all of your workforce problems. Just as a bit of a hint, the ECIST has got some fantastic resources. The best 2 places to start, other than talking to improvement managers and relationship managers in your trusts, is to go on both our YouTube website and our NHS Futures website. The links are there, and at the end of this presentation, we'll share all these things with you. But both YouTube and NHS Futures, fantastic amount of resources, both case presentations, documents and videos. And if you're struggling to sleep at night, there's some podcasts on there as well, and you can listen to our dulcet tones just help you drift to sleep. A lot more effective, clinically proven to put you to sleep than counting sheep. So this is optimizing your workforce, but that feels quite a difficult topic or term in the last couple of years. And I don't particularly go in for a lot of the American kind of business coaches. I don't really relate to them. But this phrase by Simon Sinek, that those of us who kind of have managerial leadership duties, we're not in charge of people, we're responsible for those people in our charge. And so we're just going to slightly rename our webinar today to supporting and delivering and developing our workforce. We're looking at 4 different themes today. So we're looking at the demands, i.e. the work that our workforce goes through and what work they have to do. The capacity of our workforce, so how many workforce we have, the rotas and the shifts that they work, how we support our workforce, and the environment that our workforce works in. And I always think of this little image when I think of the demands of our workforce and how much of the work that we know our colleagues or our peers, our junior doctors, our nursing staff do, and what do we think they do compared to what actually they do. And to go over this for us, we've got an expert, Chris Green, in my mind a genius. One of his best skills is the fact that he can explain very complicated things in a very simple way that even I can understand. Capacity, we've got Richard Clarkson talking, who is the head of service for the emergency department in Insured Forest Hospitals, arguably one of the most improved emergency departments, if not the most improved emergency department in the last 5 to 10 years in the NHS. We've got Dr. Ruwani Abeyratne, consultant geriatrician in Derby, to talk about well-being and coaching, who's an expert on well-being and compassionate leadership. And last but not least, because he's not actually here at the moment, is Dr. Andrew Rochford, one of our ECIST clinical directors and consultant gastroenterologist. So I'm the least important person, and so I'm going to stop talking there now, and I'm going to hand over to Chris Green to start off with our first of our brief presentations. Chris, I've got your slides if you want me to present. If that's easier, you can take over control.
That's great. Thanks, Dan. Thanks for that lovely welcome. I think I need to take you around with me for that introduction. So good afternoon, everybody. I love that photo of me, mainly because it makes me look all right. But just to
20
prove
years ago, Chris, that
it was a long time ago. Thanks very much for that, Dan. But as every hospital must have a really long corridor. That was when I used to work at a trust down at East Kent, and that's definitely the longest corridor ever. It takes a phenomenal amount, and almost need a segue to get through that. So it's great coming along and speaking today. So my background is all in healthcare analytics. I've been working in the NHS for around about 18 years now, which makes me a bit of a whippersnapper compared to a lot of the people that I work with. But it's great because the way in which that I have worked is I've never been what you would call a traditional analyst. I don't like sitting behind my computer screen and just kind of sitting in a dark corner. I love spending time with clinicians, with operational people, because that is how we learn together. It's also how we kind of move away from anecdote to put in a bit of evidence in it. And, you know, people like Dan, you know, might come to me with a hypothesis of, I think that we're experiencing this. And it's my job to either prove or disprove that hypothesis. So what we're going to do is we're going to have a look at demand. And, you know, when Dan said, oh, you know, can you come and speak about demand? You're like, well, that's easy, isn't it? You know, it's just people coming through the front door. Thanks very much. That's my presentation. Let's go away with this. But the thing that I've learned and continue to learn is that demand is just one of the most complex things that we have to deal with. Not only from a kind of a front door actually dealing with it, but my kind of background in terms of data analytics, splitting out demand, looking at different types of patients is so complex, but absolutely pivotal if we are to try and create a safe environment for both our patients and for our staff. So if we just go on to the next slide, please. I just want to kind of put a bit of context. So you'll all have seen a graph very, very similar to this, to have a look at total type 1 ED attendances over the past couple of years. Actually, as a sad fact, I'm running a pub quiz tomorrow night, and I'm actually using some NHS data around whether people actually know how many annual attendances there are within the NHS. And for those people who are interested, it's roughly about 15.8 million people per year attend a type 1 department. Cumulatively, is an interesting stat for you, that's 85 million hours. If you add up all of their time within the emergency department, 85 million hours, that's 9,800 years, which is absolutely bonkers if you think like that. But what we can see from this graph is that the pandemic has had a significant impact on the type of demand that's come through, the amount of demand that's come through our type 1 emergency departments. We can certainly see that kind of around about the March, April, May position of 2020, we saw that significant decline in the total number of patients coming through our front door. But what we can then see is how that has varied since then. So we had that kind of the semi peak around about middle of 2020, where we started to come out of lockdown. Then we had the lockdown 2.0. Can't believe I said that, but there we go. But then we're now back at a relatively consistent level of demand. However, if we move on to the next slide, the thing that's more interesting to me is not necessarily about the number of patients that come through our front door, because the number of patients that come through is not immaterial, but they will just come through our front door. But actually looking at the acuity and the type of patients that come through our front door is much more interesting. So what we've done is we've come up with a relatively simplistic way of having a look at acuity. Haven't got time to go into that now, but can talk about that at any other stage. And the interesting one for me was particularly if we have a look at the blue line, and if we have a look at the other line, we can have a look at the blue line, which is attendances. So around about the April-May position, we saw that decline in A&E attendances, but the acuity of the patients increased. And it absolutely stands to reason that in your mind, your hypothesis would come up with, well, actually, why do we see a decline in patients that come through our front door? Well, it's because people weren't leaving the house. So actually, the only people that would go to the emergency department are the more acutely unwell people. And that's kind of interesting. But I think the more interesting thing, and once again, devil is in the detail and looking at the patterns, is that over the past 12 months, we have started to see that relatively consistent amount of patients coming through the emergency department. I know there's variation across the country, but if we have a look at it from a total England perspective, but what you can see is that the acuity of those patients is actually decreasing. Now, we could talk about this not only just for this hour, but many, many more hours to come. And I don't want to kind of draw out too many assumptions around this, because we could just say, well, actually, is that because people are voting with their feet and just coming to the emergency department? Is it because there's a lack of alternatives to emergency department? Or is it because there's a lack of primary care availability? Now, data should never solve things by itself. But what data should do is it should help drive conversations going forward. Next slide, please, Dan. What we also need to think about is that demand isn't just arrivals. Okay, so we always look at demand to say how many people have come through our front door, but the problem is that would be fine if we didn't have anybody in the emergency department. You know, when people say, oh, we had 50 people come through our front door, well, if you've got no one in the department, then that's absolutely fine. However, if you've already got 50 people in your department and another 50 people arrive, you have got, guess what, 100 people I am quite good at maths. I didn't even need Excel for that. But you've got an increasing demand. So actually, what we've got in the graph in the bottom corner is a piece of work that I'm doing for an organisation to have a look at, well, how could we potentially get away from corridor care? So the red line being their fixed, being their cubicles, and obviously that is a fixed number. They can't just magically say, "Oh, please, can we have loads more cubicles?" But actually, what we can see is that the occupancy level significantly varies by time of day and by day of week. What we've also got in the top right-hand corner is a fantastic example of the potential mismatch between demand and capacity. And I know that's what's been talked about a lot today. What we've got is we've got the arrival time of the patients on the x-axis, and we've got the average minutes from arrival to being seen by a senior decision maker on the y-axis. And what you can see is that if a patient arrives, so the grey line is the national position, the black line is a hospital that I was working with, you can see the pattern's the same. So if a patient arrives at 8 o'clock in the morning, they are seen on average after about 80-90 minutes, that's an hour and a half. However, if a patient arrives at 2 o'clock in the morning, we're seen on average after 200 minutes, that's just over 3 hours. So a massive, massive difference. And you might kind of say, well, okay, well, I know that's bad, but it doesn't really matter. However, we know from recent publications that actually higher occupancy, higher numbers of people in the department leads to long waits within the emergency department. And most importantly of all, it leads to a higher risk of harm for those patients. But it also has a detrimental impact on the staff that are working within that department as well. Next slide, please. And lastly, but no means least, it's all well and good knowing, well, we see 200 patients through our department. Okay, so, what is the harm in that? It doesn't really matter, does it? But actually understanding the demographic makeup and the demographic profiling of those patients is absolutely pivotal, so that we can try and work out the services that are being driven via our emergency department and our acute pathways overall. Now, the graph that I absolutely love around this is the graph in the top right-hand corner. And what we can see is the bars are the England position and the dots are for, I was just making sure that I didn't highlight the trust that I was working with. What we can see is that there is a significant variation in the amount of time that a patient is in a department based on their age. So if a patient is in a department in this organisation and they come in, they're 10 years old, they're in a department for 200 minutes, so about 3.5 hours. However, if the patient is in a patient who comes in and they are 80, they are in a department for 800 minutes. That's nearly 13 hours. Now, I know we're not comparing like with like. I know there's a massive, massive, massive amount of difference. But should there be that significant variation between the ages of patients? But we can also have a look at the demographic makeup, the deprivation makeup of the patients. And we can also have a look at the reasons why patients are coming into the department via their chief complaints. This is part of the new UEC dashboard that has been created by myself and the team. And if anybody would like to receive a copy of this, it goes into much more detail around demand makeup and having a look at admitted patient care. My contact details are on the next slide, and I'll be more than happy to take any questions as we go through the panel. That's it from me, Dan. I'll now hand back over to you.
Excellent. And I always learn loads, Chris, when you talk, and as I say, you explain it so well, so thank you. And I've already got a couple of questions. There's a few in the chat box. We're going to save them for the Q&A panel unless there's anything pressing. Nextly, we're going to speak to Richard Clarkson. As I said earlier, Richard is head of service, the emergency departments at Shared Voice Hospitals, but also nurse in charge of the whole of that division, the emergency urgent emergency care division. And it's an ED department that I've spent 4 out of my last 8 or 9 years of training going in and out of, and the improvements it's shown over the last 10 years or so is unbelievable. And workforce is such a massive part of that, with nursing, doctors, and a fantastic ACP program. So we're going to hear from Richard. Richard, do you want me to stop sharing, or what would you like me to do?
No, I'm just going to talk if that's okay. If everybody's happy with that, much brilliant. More better at talking than anything like that. Okay, and my eyes are open on that picture. I think it's just a chubby face. I think it was a lockdown face. Anyway, so yeah, my name's Richard Clarkson. I'm the head of nursing for urgent and major care at Kingsmill. I'm an ED nurse. I've worked here for 20 years, and I've been an ED for all those 20 years. I have been the head of service for the last 6 years, so sort of moving from the nursing side to work with the doctors. So there's loads of work we've done around medical recruitment, but today I'm going to talk to you a little bit more about nursing recruitment. for any nurse in the room or anybody that's interested in nursing recruitment, then this may be of interest to you. So 5 years ago, we had, before I was involved in the divisional nursing side of it all, we had ED nursing. We were interviewing, recruiting, and we had a high proportion of newly qualified nurses that were interested in applying for ED, but only limited jobs. So what we decided to do to accommodate all these nurses working in the division was to put in a rotational program. Now, within the division, EAU, medical admissions, AME, whatever you call it in your organisation, does struggle to recruit and retain nurses. It's a difficult area for nurses to work, has a high turnover. So we developed the rotational program. Now, it's a program that covers 18 to 20 months, predominantly for newly qualified, but nurses with experience can apply who are looking for a different change in area of working. And the rotation includes 4 areas in UEC. We do it for ED, SDEC, which is our same-day dementia care unit. We have EAU, which is medical admissions, 40-bed admissions ward, and then we also have a short stay unit as well. And the idea is that these nurses will then apply throughout the next 18, 20 months. They will rotate through 6 months, 3 of those each areas, 6 months at a time, probably a little bit longer in the first one to help them get through their preceptorship without moving, so they get that completed in one area. And at the end of the program, they are guaranteed a job within division based in whichever area they feel they're most suited to at the end of the 18-month program. So we started in 2018 with cohort 1. We are now we've now got 4 cohorts that are finished, most of which are nurses are still in the division, working across the division, some at band 6 level. We have 3 active cohorts running, and I've got a cohort 8 which is planned to start in the summer, waiting for the nurses to get the pins and go through all the HR stuff. So it's a real robust program. It has improved relationships in the division because a lot of the nurses that have done the rotation are now based in ED or EAU on short stay, so fully understands each other's pressures. So it's really good sort of for building relationships and people understanding the pressures. It's kind of broke down the us and them barriers that you often find between EDs and EAUs. And having been in ED for so long, I guarantee that is a thing, because you're creating a hell of a lot of work for EAU. But actually, these nurses that rotate now understand that. They are also willing to pick up bank shifts. So if they're short-staffed in certain areas, they are willing to pick up bank shifts in other areas. So when staff move to support areas that are below minimum staffing levels, it's much more easier to facilitate because they're happy to go because they know the area. And it supports areas that don't have the ability to recruit as well. ED will always. I've always found recruitment in ED to be quite a positive thing. I know the EAU and some other areas don't. So. And it gives nurses a really good start to the career. And some of the nurses that do it, potentially at the end of it, may think, actually, urgent emergency care is not for me. I'm off to working as a practice nurse or a cruise ship nurse or in a prison, something completely different. But it will give them 18 months worth of skills that is absolutely sort of shapes them for the rest of their career. It's quite easy to organise. You just advertise, design an advert, design a SOP. And just absolutely run with it. It's designed within division. There's no reason why you couldn't do it outside of division. So you could have it going through different specialties in medicine and theatres and recovery, whatever you need. It is, I feel, that probably best suited to a patient pathway. So for our division, ED, EAU, SSU is a patient pathway and SDEC, but there's no reason why it can't follow that pathway if you need to. But I think ultimately, it does fit in better if it sits in one patient pathway. It works really well. We've had good feedback from it. The people that have done it, some people have got sort of stuck in one area and don't want to move, but then a bit of a conversation, they've agreed it's what they want to do and they move on. And we're now sort of launching the band 6 rotational program that we're just starting. So in sort of the next couple of weeks, it will be full and all the nurses will be started and they will rotate, same with an element of leadership from one of the matrons, being a consistent sort of approach through it all. So it helps recruitment. It's another way of recruitment. It's another way of getting people into posts. And for me, having an establishment full of substantive staff is absolutely paramount to quality, safety, all the things, meeting your demand, all the things about happy workforce and all the things about sort of governance that you absolutely need. You need your workforce to be on board. And if you look at completely other options than just putting an advert out, getting nobody could apply, and you need to think a bit more broader than that. And this, along with TNAs and international recruitment is just another way of maximising your workforce and filling your rota. Yeah, I mean, obviously, it's if anyone wants to know any more, I'm more than happy to ask any questions.
Thank you, Richard. And the way you've explained that sounds like such a simple program that you've set up, but I know the amount of hard work that you've had to do to put that program together, and how you've tried to encourage other divisions to come and work with you as well on that. And
definitely
an intervention that has saved an awful lot of money, improved patient care, and as you say, improved that kind of sustainability of your workforce as well. And for everyone else on the call for the Q&A session, Richard's overseen also kind of international graduate and CSER recruitment of medical of ED registrars and consultant programs. So if you have any of those questions, again, hold them up for the Q&A session later. So we've talked about, thank you, Richard. So we've talked about demand and capacity, and the next bit, which I think, to be perfectly honest, at the moment, with thinking back over the last couple of years worth of work that we've done and the unprecedented demand that we've all had to deal with, we're now talking about supporting our workforce. And so we've got Dr. Ruwani Abeyratne, who is a consultant geriatrician at Royal Derby Hospitals at the moment, and is an expert on well-being, a professional coach outside of work. I don't know how you find the time, and also an expert on compassionate leadership. So over to you.
I'll unmute. Thank you, Dan. Thank you very much for having me. I don't know if you've got another slide for me with my three headlines. So there we go. So Dan's given me 5 minutes to talk about supporting our colleagues, which obviously is nowhere near enough. So what I thought I would try and do is slow it down a little bit, break it down into manageable chunks, and talk about these 3 headlines that for me are what it comes down to. So what do we need? What do our colleagues need to thrive at work? And I'm taking you back to Dan's first comment about coaching lingo. And thrive is one of those words that I really struggled with right at the beginning of my coaching and leadership journey, but it is absolutely the right word. What do our colleagues need to thrive at work? Once we've understood that, what are the barriers that exist to stopping this? So why aren't they thriving, or why aren't we thriving? And once we've identified those barriers, how can we dismantle them? It's all very aspirational, but that's okay, because we've got to aim high. And I think that the NHS is great at doing that. So I'm not going to, I haven't got loads of slides. I'm literally going to talk about it, but I'm going to leave those 3 questions there just to sort of help you to guide your thinking on this. So if we talk about colleagues thriving at work, I think the first thing to try and understand is, how do we create the space that colleagues need to do their jobs to the standards that we know they want to do? So I don't know any colleagues who aren't there to do the best that they can. And yet we're all struggling. It's tough out there. And so because I'm a doctor and my regulatory body is the GMC, I'm familiar with what they're saying about supporting our colleagues. But actually the themes that they pull out are relevant to all professionals. So we hear repeatedly things like autonomy. How do you create a sense of belonging? People just want to be good at what they do. But how do we go about doing that? How do we ask those questions of our colleagues? And what underpins the reasons that people come to work? So for me, over the course of COVID, revisiting the reasons why I come to work has been really important to help me to centralise and align myself with why we're here, with all of the challenges that we're facing. So there's something about how you engage your colleagues in their values and how you align those values to the values of the system that we're working in. And that's challenging, because the values of the system don't always equal the values of individuals. And in the NHS Constitution, the word compassion and compassionate does appear. And I think that's something that we sometimes take for granted as healthcare professionals. But we all practice it, we all do it. So how do we create these spaces where people can explore these, what you might call softer skills or softer attributes that are so fundamental to us thriving at work? And obviously, and what I'm really grateful to Chris and Richard for coming ahead of me, because what we know we need is systems and teams and processes that support that. But actually, how do we enable our colleagues? Part of it is identifying barriers, and we have simple ways to do that. And we all know the common things. Our workforce is short, sickness leave is high. There's threats to our ability to do this. So COVID is a really good example of a threat that we didn't see coming that stops us thriving at work. It added uncertainty, more uncertainty. And then there's mandates. So other people telling us what we need to deliver and how we deliver it. But what that comes down to for me is control. So a lack of control in your professional workspace, in your sphere. And how do you give back some of that control? What's that control about? Because for all of us on this call, it will be different. So what's in my centre of control will be different to what's in yours and those around us. But the reason that that's important is because that brings us back to those values and that compassion and that autonomy, the competence that we talked about in what people need. So when you enable people to take control, hopefully what you do is start to create the environment that they need. And I know Andy's going to talk more about environment in order to thrive. The risk of not doing that is what we're seeing around us, that moral injury and burnout. And I would go into the details of all of that, but I don't think I've got the time. And we know that there's a problem here because the NHS staff survey tells us that. And whilst there are loads of positives to take away from the staff survey, I think there is a huge amount of learning for us to do about listening to what our workforce and our colleagues are telling us about the barriers to us thriving in the workplace. So I've talked about barriers, I've talked about why we're not thriving. So how do we do it? How do we dismantle those barriers? And for me, it's very simple, perhaps I oversimplify it. But what we need to do is create a safe space in which people can learn. And there's lots of different ways that we might talk about doing that. So for me, there are two major components to this. When you talk about culture in the workplace within our NHS institutions, do we have a coaching culture? Do we have a culture in which people ask probing questions, difficult questions? Or do we have a culture in which people are afraid to speak up, which people think that they should know the answer, but they're not quite sure? So the next thing in that is creating areas of psychological safety, arenas where people feel that they can learn from the mistakes and learn from the challenges. I don't have time to go into how you create coaching cultures or how you develop psychological safety right now, but hopefully that will come up in the question and answer session, and I'm more than happy to talk about it, but I will hand over to the next presenter.
Well, thank you very much, Ru, and I'm sorry that we're trying to fit so much into our quick webinar, but I will share links with everybody later where Ru has had more time to spend. We've got a whole YouTube video of Ru explaining some of these things, and I've wrote down a couple of questions I'm going to ask you in the Q&A straight away after Andy's next talk. So thank you very much for that brief, again, amuse-bouche of well-being and psychological safety. So last but not least, we've got Dr. Andrew Rochford, who's a consultant gastroenterologist at Royal Free in London, and also one of the ECIST team, our boss. So thank you very much, Andrew, for coming, who's going to be talking today about the environment that we all work in and how changes or improvements to the environment can improve our optimization of our workforce.
Thanks, Dan. Have you got are you going to drive the slides? Is that okay?
I've got your slides up. Yep, they're all ready.
Lovely. So go on to the next slide if that's okay. And it's always difficult following Ru because actually the presentation, I don't know about anyone else, but I'm now sort of, my thoughts are totally distracted and just need a pen and paper and some green tea and sit in my garden and think about things. So it's a pleasure to join the panel today. Thank you, Ru, for another thought-provoking talk. And apologies in advance because I feel like a bit of an imposter when talking about the environment, but I was part of the Modern Ward Rounds working party with the Royal College of Physicians and have been invited through that for reasons that are not entirely clear to me on some roundtable discussions with architects and design people, and so I'll share some of my thoughts around that. So just a couple of slides, really, again, an amuse-bouche, some pointers, some thoughts. Just a bit of history. We've been talking about health, architecture, healing since the early 1990s, certainly in terms of the literature, and it was originally called evidence-based design, has morphed into what we now call and possibly experience as healing environments. And what I wanted to highlight very briefly is that there is actually a cost benefit to this. So there is a clinical evidence base around the fact that healing environments save money, they're more efficient for staff, they reduce in-hospital length of stay, and are better for patients because their stay in hospital is less stressful. There's some good evidence that they reduce errors, things like infection rates, falls, and they are beneficial in terms of privacy, comfort and control. A little bit of caveats around that. A lot of the evidence base is what we would traditionally talk about qualitative, so thinking about the softer aspects of the environment and things like acoustic measurement, and I'll come on to an example around this, and the staff outcomes are qualitative rather than quantitative, but just to say there is an evidence base that this is cost effective. Next slide please, Dan. And I thought it would be helpful to just share some of those slides with you. There's a fantastic piece of work that was led through the King's Fund 5 years ago called Enhancing the Healing Environment Programme. The link is on there. There are over 250 organisations across the health and social care environment, with all the case studies written up available for you to look at. So this is not all about a medical ward, it's everything across the health and social care environment, and you can just click on and read the case studies there. Someone that I was privileged to be part of a discussion with is Diana Anderson, who set up this this concept almost called the Docitect. Diana is a qualified architect from the States, who then went on back into medical school as a mature student, is now a consultant geriatrician in the States, but has set up this bridge between architecture and medicine, and has done a lot of actual clinical research looking at the environment, particularly for frail elder patients in hospital, and highlighting just how unfrail friendly hospital wards are, and simple things like the height of windows. It's incredible stuff. They've got a website with resources for you to look at, and there's a lovely set of YouTube videos that are short and long for you to have a look at. Really, if you've got a quiet time, have a look through it. It's fantastic. And then in our own work within ECIST, we were fortunate enough to be able to work with Emma Stockton and the team at Great Ormond Street. I'm sure we'll be able to share the recordings. I'm looking virtually at Crystal on the screen because I'm terrible at sharing links, but Crystal is amazing at doing this. But Emma gave a keynote presentation last year. She's an anaesthetist at Great Ormond Street, but also is the clinical lead for design at Great Ormond Street, and they run a course for clinicians. And finally, what I wanted to do is highlight the fact that we don't need to reinvent the wheel. We had a really good improvement programme called the Productive Ward, Releasing Time to Care, that is now 12 years old, and it's not out of date. So I'd really encourage you to go back to the shelves that you've got your Releasing Time to Care booklets on, blow the dust off of them, and look out the one around the well-organised ward, because actually that would go a long way to improving the environment for you and your teams. Next slide, please, if that's okay. Just finally, 2 examples from the modern ward rounds. I have to say, if I'm brutally honest, and I know that this is being recorded, our advice on physical environment was pretty limited, and that probably reflects the scope of the document and the pace at which we needed to do the review. There's a lot more out there, but there are 2 really nice case examples for you to look at. One is from Yeovil. Zabir Khan and colleagues down there did a very simple improvement technique approach to reducing the sound quality or sound levels on their wards, because they were noisy, not healing, very disruptive and very unpleasant to work on, which probably resonates with most of us. And they just set up a decibel recorder and actually reduce the noise and demonstrate a reduced length of stay and better staff and patient experience. Our colleagues in Sweden, Valdemar Erling, who set up the wardround.net programme. I think he's in Gothenburg. Forgive me, Valdemar, if I got that wrong. But they set up their ward round. They bring the patient out of the bedside into a more comfortable environment and do the ward round there. So not only getting the patient moving, but actually providing a better environment. So just on to my last slide, which is a summary slide. So just my thoughts are that care is often provided in spite of the environment. I think there is definitely an evidence base. If you're looking for business cases to paint a ward, for example, or do something, put lockers in, there's a business case for that. Really engage your staff, really engage patients. We just share an anecdote from my own organisation. I spoke to a patient who said she wasn't sleeping, and I asked why, and she said it's because the night staff don't turn off the TV. Now, it's silly, isn't it? But running the TV in a bay of 5 patients, 6 patients throughout the night is not going to help people sleep. So there's lots of examples I suspect are going on that you don't know about unless you ask people. We're all about a QI approach. The examples I've given lend themselves to QI methodology. We can support with that. And just final thought is to think differently, but don't reinvent the wheel. So there's lots of things in our control. Go and look out for things, ask your staff, and they will help you. So that's all from me. Thank you very much, Dan, for the opportunity to speak. I'm very happy to take further comments and questions.
Excellent. Well, thank you so much, Andy. And that's the final of our 4 short presentations. As we said earlier, each of those presentations could have easily had their own hour on their own, or even a whole series of webinars, but that was just to give everybody a little bit of a flavour about what we wanted to discuss today, and able for us to kind of show people the work that we in ECIST can support people doing, and also link people to different references. Probably stretching the analogy a little bit too far, but those were the 4 little tasters, and now onto the main course, which is our Q&A with our expert panel. And our expert panel has been joined by Dr. Rob Cullum. And I don't normally share graduation photos of our expert panel, but this is quite timely because, Rob, you graduated this morning from your Masters in Medical Education at the University of Nottingham. I stole this off Twitter. Rob, he's clinical lead for a couple of really interesting programmes in the Midlands and works for the Midlands Workforce Team. One project that he developed was Connecting Futures, a refugee doctor programme in the Midlands, and a new allied medical role, the medical support worker role, is also clinical lead for in the region. Rob is a trainee general practitioner and also is one of the network leads for the LGBT network in Lincolnshire. So Rob, I thought, would, as a valuable addition to our expert panel because of his work with recruitment and retention and well-being of staff. So everybody on the call, we've got 20 minutes to ask our 5 expert panel as many questions as you'd like. I love the sound of my own voice, so I'm just going to start if that's okay. And Chris, I don't know if you're back. Chris, I was just going to ask, while people are kind of warming up and getting their typing fingers ready, Steve made a very good comment that acuity is not all that kind of relates to length of stay and admission and how much work there are for the staff. I often find that some of the simplest admissions with very little medical needs just takes just as long as the very sick patients in resus. Have you noticed anything that has kind of correlation to length of stay? Does acuity, is it solely age, is it method of presentation? So,
I mean, the one that's stuck out for me, which is why I put it into the slide set, was around the age of the patient. But I think somebody put into the chat box though about acuity and dependency, and those things are not necessarily always linked. So I think there's a big difference between acuity and dependency. The age is really important. And when I worked at a trust, I also did a bit of work to have a look at the presenting condition as well, to have a look at the variation in there. And there really was. I actually did it from 2 different aspects. I did it from the staff's perspective so that we can understand about the profile and makeup of patients, but also a patient expectation, so that a patient knew that on average, if a patient came in with a gastrointestinal problem, on average they're in the department for 2 hours or however long it is. Is there some correlation work? There is, and I can point people into that direction as well.
Thank you. And then I thought, moving on to kind of the capacity of the workforce, which is a bit of a difficult term, but increasing our workforce recruitment and retention. I'm going to come to you, Rob. Obviously, you've been involved in some quite innovative projects to try and improve the workforce, increase the workforce, improve recruitment. Do you mind just kind of giving your thoughts on kind of innovative ways of improving the workforce, and maybe a few examples on the work you're doing.
Thanks, Dan. I think really the key thing is that we know that when it comes to finding new workforce, that they're not just hiding under a park bench somewhere to be found as such, and we do need to be more innovative in what we do. And I think that's been really spelled out with the work with the medical support worker programme in the region. So for colleagues that aren't familiar with the medical support worker role, this was a role that was created by NHS England at the start of the pandemic to support with clinical delivery, and what it's an unregistered role, but for people who are medically qualified. And as it's turned out, most people that are currently working this role and continue to work in this role are international medical graduates who are working through their process of gaining registration with the GMC to then enter the registered medical workforce. And what we're seeing in some of the areas in the Midlands that really struggle historically with recruitment for medical staff is that these individuals are being nurtured in departments. They're spending 6 to 8 months potentially there, gaining their registration, and then joining the substantive medical workforce in those institutions. And I think looking at that differently and really bringing and looking after nurturing these individuals is supporting them to join workforces, particularly in places where people don't necessarily look at a map of England and go, do you know what, I really, really want to work in Lincolnshire. And I pick Lincolnshire because that's where I'm based, rather than any other reason. But people don't look at Lincolnshire like that. But actually these individuals are quite prepared to move and join the workforce. They're looked after, they then join long term. And I think taking opportunities like that to look at new workforces that are there whose skills aren't being used. These individuals often are doing care work. They may be working in McDonald's, one of ours came from, so they're not using the incredible level of skill they have. And I think that we do need to look for these kind of innovative and alternative sources to add to our workforce.
But of course, because they've come from different roots and backgrounds, they need a different level of support, don't they, Rob, in terms of their mentorship, their career coaching, etc.
They do, and I think the way that we often talk about this is the fact that from the perspective of an employing trust, it's an investment. They will need more support in that time that they're working with you as a medical support worker, but what that investment is that you can then translate these people into substantive members of your team, and I think that's really important. So yes, they need support, but conversely they're incredibly skilled, and I think the other thing to really highlight linked to that is the fact that they bring something back to the wider team as well, beyond the clinical care they deliver. Some of the feedback that's come out of the national survey that's being analysed at the moment is the fact that the teams learned as much from MSWs that they had working with them as MSWs potentially learned from working in the team. What they learned may well be different, but alternative ways of doing things and a better understanding of different cultures have been two of the really big things that have come out of working with individuals who've worked in a different healthcare system. And I think it's a really nice way to look at it, that this is a two-way relationship. It's not just about what that individual brings to you, it's what you bring to them, both in terms of delivering clinical care, but also that wider team development both ways.
Excellent. Thank you, Rob. And just coming back to you, Richard, if you don't mind, and I'm going to link Rob's question to a comment that Andy has put in the chat box about kind of competency-based care within our emergency department. So I come to you because you've got international doctors, ACPs, junior doctors, consultants, and we're just talking about a relatively novel role called the medical support worker role, but ACPs and PAs in some hospitals are still quite novel. So how have you gone about, as a head of service, approaching the different for want of a better word, what patients are seen by which professionals in your emergency department?
Yes, I mean, obviously we have clinical fellows that are sort of this is the first job in the NHS, and in the UK we have a team of ACPs, obviously, that are of varying backgrounds, paramedics, nurses, ED nurses, ITU nurses tend to be the main thread of staff we pull from. We have a wide team of Caesar doctors that sort of are our registrars that sort of run the department overnight and provide sort of running resource and being sort of the go-to people really, outside of the consultant body, that are from all over the world really, and of often this is their first job again in the NHS. So I think it's just about sort of individual basis really. They will all bring something different, and a lot of them have worked outside of their home country, so maybe the first job in the NHS, but actually they're quite really diverse and adaptable to change, because a lot of them have come via the Middle East and they've worked in different countries outside of their own country. So whilst it's a challenge again to come to a new country, they've also got great skills in being diverse and adapting to change quite quickly. It's about treating them as individuals and looking at their previous experience. As a newly qualified nurse, my experience was pretty much on par with everybody else that I qualified with. Having spent the last 3 years with them, but albeit a very long time ago. But there is a high proportion of these doctors and nurses that are, and ACPs, that are coming in with different experience and backgrounds, and it's really important that we understand that before we put any kind of plan in to support them, because you don't want to sort of upset them and sort of belittle them, but you also need to make sure that any development they get is personalised around what they need and actually relates to what direction they're going in and what they did in the past before they came to work in the NHS.
Thank you, Richard. And I think that brings us back to Ru. I think that in supporting our workforce is that there's challenges to supporting a more and more diverse workforce, but so many great opportunities come from that. And I worked on the medical support worker program like Ru and like Rob, and it's such a successful program, but also so satisfying as well when you hear these personal journeys of people going into working in substantive NHS positions. You talked earlier about needing more time, and I'm going to give you that time now, Ru. For people coming into the workforce, how do we make sure that the team's kind of psychological safety as a whole, if that's the right phrase, allows people new to the team to raise concerns, to ask questions, to feel part of a supportive culture?
Yeah, it's I wish there was an easy answer that I could give to that question.
Okay, we'll move on then.
But you know me, Dan, and there's something about accountability here. Accountability from leaders, accountability from clinicians, accountability from colleagues. So what does psychological safety mean? It means that somebody can speak up without fear of retaliation or humiliation when they experience a mistake, so that what you're saying is, we're here to learn from our mistakes. So how do you create that environment? First of all, you acknowledge it. You acknowledge that we're all here and we're all learning. So I've been a doctor for 12, 13 years now, and every day I am learning. And I'm learning from people who haven't necessarily been practicing whatever their profession is, not necessarily just doctors, for as long as I have. And I'm learning from people who have been around for a lot longer than me, but maybe aren't recognised as having the skills that I have. And so there's that collegiality that I think we had during COVID, I think we had during our lockdowns, that we need to foster and develop. And we know that people who feel able to speak up then are the seeds of further development. But it's really about setting a standard, isn't it? So if somebody is new to your team, you introduce them to the values of the team, and there is something about acknowledging your shared values. And the values piece is really important. And there is an assumption that we have shared values as people who work in healthcare. But I think what Richard's alluded to is that we come from such diverse backgrounds, and we each have our own agenda, and we each have our own purpose. All of it is important. So whilst we're all working towards a shared vision or a shared purpose, we're individuals as well. And there's something really important about acknowledging that and then giving people the space to talk about that and to grow.
I was nodding along, and just like Andy was talking about earlier, I was kind of thinking about all the different things I need to do this afternoon and the different thoughts you've triggered. Andy, you've got your hand up. Over to you.
Yeah, just quickly, Ru. I mean, I guess one of my thoughts is actually re-establishing team. It's kind of particularly post-COVID or during COVID. Well, during COVID itself, actually, particularly the junior doctor workforce, aligned with ward-based working, we got back into a team spirit. And actually, we talk about sharing these values amongst a team, but I think we've kind of gone our separate ways again with, you know, different teams on different wards and safaris, all that kind of stuff. So actually just going back to basics and going, we are a team, let's talk and think as a team would be a good start.
Yeah, I mean, I totally agree with that. And I think I would almost suggest that at the moment we've moved so far from the team because we are so short-staffed. So, and I'm speaking from my anecdotal experience of my colleagues around me, but I'm sure it is the same across the country. Teams are changing every single day, and it's not just the on-call teams, the baton teams that we were used to previously. This is ward teams that are changing every day. So the psychological safety concept comes from Amy Edmondson in the States, but she also talks about that concept of teaming. So how do you build an acutely collegiate atmosphere with a group of people who might change on a day-to-day basis? But yes, the team, where else do you get that sense of belonging from if not from your team?
Yeah, I was going to come to Rob to kind of follow on with that point. Actually, Rob, you're a junior doctor, a fellow junior doctor like myself. I know we're not allowed to use that phrase anymore. Rotating around different hospitals. Then we've had the virtual working that you're doing at the moment, working for NHS England. So, have you examples of a good team? Have you noticed ones where the kind of teams are more inclusive than others? What's your thoughts?
That's a really difficult question to answer because it varies so much. I think my experience straight away is that a good team as a rotating doctor is the team that you walk into and there's clearly an expectation that you're a team from day one, and that's set much more from the non-rotating staff. And for me, the biggest way you know that works is the way that doctors and nurses predominantly, but indeed all healthcare professionals, interact with each other on a given ward. And the most effective places and the places I've most enjoyed working in my career have been where it's felt as one really large team where everyone, including those that are unregistered staff, your nursing staff, doctors, the physio, the OT, the pharmacist. I'll stop before I list every profession under the sun. But fundamentally, you operate as one. And I think that's really important. And then you can have some of the more difficult conversations that inevitably happen at times. But as Ruz said, you've got that psychological safety because you know you're a team and you know from day one without questioning that you're all working towards the same goal. So if you disagree on anything on the way there, it's because you're disagreeing about how best to get to the same goal. But the shared value bit is there from the beginning. And I'm lucky to say that I've worked in very few places where that hasn't been the case in my career so far. I can only think off the top of my head of one clinical environment I have worked in where there hasn't been that immediate trust from the beginning. And I think that does then leach into your rotating staff and is really important.
Thank you, Rob. And I was going to come to Andy last but not least to link that team back to the environment. And is there anything we can do with the structure of our wards, our outpatient departments, our office space to actually try and enrich that team? Because otherwise, some of the historical teams as doctors were the ward firm. So it was doctors not working with nurses and things. But I say the best teams I've ever worked on, we ate lunch together, we have cups of tea together with the nurses, with the physios, with the pharmacists. Like Rob, I'll stop listing allied health professionals now, but what's your thoughts, Andy?
Short answer, yes. That's it. No, I just before I do that, if I may, I just want to share a reflection for everyone on the call, because as we're talking, you know, I'm busy reflecting, which is the value of these events. You know, firstly, I think we are very privileged within medicine, or as doctors. We rotate round. It's very structured. If it's not well supported, there's trouble, because, you know, with GMC reports, all those kind of things, it's heavily supervised, heavily scrutinised, and sometimes we forget how fortunate we are, even though it is very challenging. The other thing is that not all areas are equal. So by which I mean, you know, you've got intensive care, you've got ED, which are very shift pattern orientated. Teams still exist. There are challenges, but it's not the same as a care of the elderly ward that's got locum staff really struggling with nursing, you know, vacancies that are sitting at 60+%, you know. So for those on the call who are looking at this holistically within an organisation, be mindful of what you're listening to and aware that you're probably not hearing from all the specialties and all the wards and all the professions, because it's the doctors at the table, the leads and all those kind of things. So that was my first thought. In terms of the environment, I would, from a personal perspective, we need to start with our own clinical team. So in my experience, what worked really well was the ward I worked on was a dump. It was grotty, it was dirty, and actually the people making it dirty were our staff and our team. And I just spent a couple of days taking some photos, showing people that actually it was us leaving the notes out on the side. It was us not tidying up our sharps and leaving them in front of the ward clerk. You know, there's a lot of that that's in our control, and just sharing that with people and for us to take responsibility. I think as doctors, we are naturally seen as the people to turn to and lead by example. So if I don't wash my hands, my juniors won't wash my hands. If I don't tidy up behind me, other people won't. Those kind of things, silly things, but role modelling is absolutely essential when it comes to the environment. And then just engaging with the teams and engaging with patients about what the experience is of working in those environments. And I don't know about others, but I've been working in several hospitals over the pandemic, and I'll take critical care as an example. They are now all nice and shiny and really nice environments with big spaces, rightly so, because they were horrible before. But then I go back onto the care of the elderly ward and it is just as unpleasant as it was pre-pandemic. And it hasn't got the sort of attention and those kind of things. So for those on the call, just the best thing I can advise, we do place audits, which are patient-led assessments of care environments. For my nutrition hat, that I get quite involved in those, which is an odd thing to do, I guess. But walk around and have a look, and have a look behind the curtain, as it were, and there you'll find the environment, and that's the environment that a lot of your staff are working with. Support them, listen to them, and change it.
And I think that's a fantastic summary to our presentations today. So thank you very much, Andy, for that summary. I'm just going to direct people to a couple of resources, and while my computer's waking itself back up again, just going to say thank you to our expert panel. I could keep talking to you guys for the next few hours, but I think we'd just be talking to ourselves in a bit. But so today was just a bit of as I say, a taste of the different things that we as ECIST and what other resources out there can do to help with your workforce. A few excellent examples from Chris, Richard, Rob, Ru and Andy about different ideas that we can do. Granted, a lot of this is quite doctor centric, but I think important that some of the stuff that people like Ru and Rob were talking about definitely cross-cuts across all different elements of the healthcare service. Just a couple of resources, and we'll share these PowerPoint presentations things with you guys later, but on the screen you hopefully are seeing links to our NHS Futures website and our YouTube website. You can, if you enjoyed hearing what Chris was talking about earlier, you can look at all the demand and capacity tools and look and get in contact with us for assistance in doing some modelling of your teams and your departments. Looking at capacity and improving your workforce, as I said earlier, there's a podcast series that you guys can listen to without having to watch the videos, and there's lots of different examples on there about improving workforce. This one is from the Brighton team. And support, Ru, as I said, has very kindly previously on the Modern Wardround Collaborative done a longer webinar for us, and so on YouTube you can look at a previous presentation on wellbeing and culture. And Ru, as a professional coach, does free sessions if you follow her on the Instagram and her emails there if you want to get in contact for any further information. And finally, for the teams that are on the ward as part of the hospital and discharge programme, We are going to be developing the workforce ideas in Fuller. We've got 4 further webinars being developed over the next 6 months, and the improvement managers that you guys are aligned to, with support of the experts on the panel, will be able to kind of work with you on your projects, hopefully using improvement methodology, as Dr. Rochford talked about earlier, to improve your workforce retention, recruitment, etc., all with the purpose of trying to optimize our workforce. So I think that leaves me finally just say thanks again for everyone for coming for today. I hope it was useful. I hope you managed to have your lunch during and we didn't interrupt your day too much. And thanks again for our expert panel, Chris Green, Data Genius, Richard Clarkson, overseeing one of the most improved EDs in the country for the last 10 years, Rob Cullum, graduated today, fantastic photos, very kindly is not in the pub and has come to our presentation today. Ru, consultant geriatrician at Derby, an expert on all things well-being and compassionate leadership, and last but not least, Andy. Okay, so finally, so excellent, everyone. Only 2 minutes over, so my chairing is getting better. So nice to see you all. Thank you very much, and we'll see you on the next webinar, which, Crystal, remind me, is in a week's time, 2 weeks' time?
It's next Tuesday, the 17th of May, and it's on job planning.
And if anyone would be very kindly to fill in our survey and tell us how wonderful we all are, it takes about 2 minutes and the link is in the chat box. Thank you, guys. See you all soon.
Bye-bye. Thank you.
Thank you. Bye-bye.